Okay, good afternoon once again. Welcome to our session on opioid analgesics. We said opioids and opiates, for example, morphine, are highly effective drugs that are used for the relief of pain. They mimic three families of endogenous opioid peptides, and these are the enkephalins, the endorphins, and also the dynorphins. Let's look at the drug actions and the receptors. We said agonists produce analgesia, but also cause respiratory depression, sedation, and euphoria. So these are the actions of these drugs. Okay, they are used for pain relief, but also at the same time they can produce respiratory depression, sedation, and also euphoria. Euphoria is like feeling of self-contentment, and you just feel proud, and it's just like the same feeling people have when they become intoxicated, when they become drunk with alcohol, and you just feel excitement, self-contentment, and you're just excited. They can also decrease the gastrointestinal motility and also cause psychological and also physical dependence. This is also one of the problems with this drug. They cause dependence. Somebody becomes addicted and cannot do without them. Sometimes when you use them for a long time. Agonists and antagonists, others are passive agonists. They provide a lesser response than the agonists and can also block agonists at higher dosages. The antagonists have no responses and they block the agonist. Let's look at morphine, which is perhaps the commonest one we have within our jurisdictions. So morphine is extracted from an opium found in the coffee plant. The pharmacologic action, it acts as a pure opioid agonist, potentiating the actions of an opioid. And the therapeutic uses, it is used for relief of moderate to severe pain, and also preoperatively for sedation and also an anxiety reduction. Okay, so many a times these are drugs with high uh, for management of high pain threshold, like cancer patients. Many a times they feel a lot of pain, and you find the other analgesics might not be of help. Things like paracetamol or diclofenac might not be of help because the pain threshold is high, and that's why sometimes morphine is used, even like morphine, for these particular patients. Uh, Looking at the adverse effects of morphine, we say the most serious adverse effect is respiratory depression, although it is not common at therapeutic dosages. So normally when we give the right dosage, we are not worried of this adverse reaction. But if in case we give more than the normal dose, of course we have to be worried of some of these adverse effects. It also causes constipation, orthostatic hypotension. Okay, this is dropping in blood pressure while standing, while waking up from standing. Sorry, wait, while waking from sleep, the standing position. Urinary urgency, okay, standstill or retention, and cough suppression, and also other adverse effects. Morphine can also cause vomiting, emesis vomiting, and also increase intracranial pressure. Euphoria and also dysphoria. We have already mentioned about euphoria. Dysphoria is just like that abnormal and bad kind of excitement because of morphine defects. Also, there is neurotoxicity. Meiosis is a constriction of the pupil in the eye. It becomes pinpoint small. Okay, instead of dilating, it is becoming small. And then it can cause tolerance and also the physical dependence. We talked about addiction. So it becomes difficult to live once a patient that you getting used to injection with morphine all the time. He feels like all the time he's injecting himself with morphine. And normally we prescribe them for a short period and to minimize this issue of physical dependence. Okay, morphine withdrawal. This is applied for people who we have been treating with morphine and we are trying to stop, or people who are already getting addicted and really they need to withdraw. Okay, so withdrawal syndrome can include yawning, rhinorrhea. Rhinorrhea is like runny nose, sweating, anorexia, loss of appetite, irritability, tremors, restless, okay, those pimples on the skin, violent sneezing, weakness, nausea, vomiting, diarrhea, abdominal cramps, bone and muscle pains, and even muscle spasms. Children, these are newborns, neonates exposed to morphine in utero, like if the mother had been taking morphine while the baby is, while the fetus is in utero and then she's delivered, this one might require tapering. That means like they may need some small dosages of morphine. I mean, with paregoric, which is the things like opium, gradually so that they don't suffer from withdrawal effects of morphine. Other strong opioid agonists, we have new opioid agonists such as alphentanil, fentanyl are 1,000 times and 100 times respectively more potent than morphine with the same efficacy. So, overprescription of opioids has been regarded as a significant mistake in modern medicine. So, always we should really never overprescribe this drug because of the issue of dependency. Moderate to strong opioid agonists, we say drugs like codeine and oxycodone have similar effects and adverse effects profile as morphine, including pain relief, analgesia, respiratory depression, and also abuse potential, the risk of dependency. Opioid agonists and antagonists, it agonists at low doses but antagonists at the higher dosages. Pentajocin and buprenorphine are examples of drugs used for withdrawal and maintenance as well as depression. So you see them acting within all these intermediaries. Clinical use of opioids is actually pain. Okay, the objective assessment of pain is challenging as it is subjective. So sometimes we don't know which pain, like what is the level of pain of this particular person. Are we going to give now the high the highly acting pain relievers, or we can still use this person on the others like the non drugs that does not that have a low pain threshold. So sometimes the problem is assessing the pain, but this always uh, works well with experience and also fair clinical judgment based on experience. Patients may overreport pain to seek euphoria or underreport due to fear or addiction. So this is also what makes it a bit difficult. Somebody may really pretend to be in too much pain, but just because he wants to get the drug to feel high, to get that excitement. Always should be withdrawn slowly over 3 to 10 days to minimize withdrawal symptoms. Now let's look at the opioid antagonists. Naloxone is used immediately reverse opioid-induced effects such as analgesia, sedation, euphoria, and respiratory depression. Metylnaltrexone and albuterol are used for opioid-induced constipation. Naltrexone blocks opioids euphoria but not the craving, and it is used for opioid and alcohol abuse. These are some drugs that have also been tried for patients that we need them to withdraw from opioid and also alcohol abuse. Non-opioid CNS analgesics. Tramadol is a moderately strong analgesic that blocks the uptake of serotonin and norepinephrine. Polanidine and dexmedetomidine, a central alpha-2 agonist, used for severe pain, but they also have abuse potential among the opioid addicts. Drug abuse involves the use of substances inconsistent with medical or societal norms. Look at definitions and diagnostic criteria for drug abuse. Okay, by definition, say drug abuse refers to the use of substances that are inconsistent with medical or social norms. With my own observation, I've seen an increase of abuse of tramadol in recent years in Cuba, where even people move around in the villages looking for drugstores and clinics that gives them tramadol as an over-the-counter drug, which was something that never existed, like some 4 or 5 years back when I was working in Cuba. So addiction is a chronic relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences. We might have seen what happens with the alcoholics who are already addicted. Also, the intravenous drug abusers. Tolerance, psychosocial, psychological dependence, physical dependence, and cross tolerance are important concepts that are related to drug addiction. We have DSM-5 substance-related addictive disorders criteria. We have impaired control, larger amounts used for a longer period of time. This is a criteria for diagnosing people with already addictive disorders to a certain drug. Also, these people have multiple unsuccessful efforts to cut down spending. And then also spending much time obtaining or using or recovering or craving for this drug. And then they have social impairment, falling in major role obligations, continues despite problems from use and giving up on other activities. We also have what we call risky use, engaging in hazardous situations and using substance despite awareness of the problems. And then pharmacologic criteria is we have the tolerance and withdrawal. With this, we have come to the end of this lecture. I thank you for listening and bye bye.